Welcome, future doctors. If you're gearing up for your MUHS MD Pharmacology exams, you are in exactly the right place. I'm super excited to bring you this masterclass explainer on pharmacogenetics and pharmacogenomics. Look, this is your ultimate high-yield blueprint for those long-answer questions. We're going to build this up conceptually from ground zero, so even if the topic feels a bit overwhelming right now, trust me, by the end of this, you'll be writing absolute textbook perfect exam answers. Let's get into it. Okay, so here is our agenda for today. First, definitions and basic concepts. Then, CYP2D6 and acetylation polymorphisms. After that, G6PD, HLA, and other variants. Next up, precision medicine and oncology. And finally, we'll wrap up with a rapid-fire Viva Q&A. Section 1. Definitions and basic concepts. Getting top marks means nailing these definitions right out of the gate. So here's exactly how you want to frame this for your examiner. Pharmacogenetics is kind of the older term, right? It refers to those familial, idiosyncratic reactions to very specific drug classes. Pharmacogenomics, on the other hand, is the broader, more modern term. That's where we look at complex, population-wide genetic variations to actually personalize medicine. To lock this in, just use this simple mnemonic. Genetics equals group or family reactions. Genomics equals global or population-wide application. Think of genetics as the family tree and genomics as the entire forest. Now zooming way in, our genome is basically our complete DNA instruction manual. And the most common way these genes vary from person to person, that's the SNP, or single nucleotide polymorphism. You absolutely have to define this clearly in your exam. A SNP is a heritable mutation that pops up once in about every 300 bases. That means there are roughly 10 million of these little variations scattered across the human genome. It's actually mind-blowing when you think about it. Just a tiny single-base mutation, literally one single letter changing in the DNA code, can completely change how your patient responds to a drug. Moving right along to Section 2, CYP2D6 and acetylation polymorphisms. Pharmacology examiners literally cannot get enough of these liver enzyme variations. Imagine giving the exact same drug to two different patients and getting totally opposite results. Let's talk about codeine. Codeine is a prodrug, meaning it actually needs the CYP2D6 enzyme in the liver to convert it into active morphine. Well, if your patient happens to be a poor metabolizer, that conversion just doesn't happen. The clinical consequence? Total treatment failure. They get absolutely zero pain relief. But what if they're an ultra-rapid metabolizer? They experience this massive, rapid conversion into morphine, which leads to severe toxicity and potentially fatal respiratory depression. Crazy, right? Next up, we have acetylation polymorphism. You need to know the isoniazid, or INH, story inside and out. INH relies on hepatic acetyltransferase to be metabolized, and this actually shows a bimodal distribution in the general population. Basically, you're either a slow acetylator or a fast acetylator. Slow acetylators accumulate the drug, stretching its half-life out to about 3 hours. Fast acetylators, they clear it really fast, with a half-life of just 1 hour. The absolutely crucial exam point here is that slow acetylators accumulate INH, which leads to severe vitamin B6 or pyridoxine depletion. That puts them at extreme risk for peripheral neuropathy. So what's the real-world clinical trade-off? Well, slow acetylators are definitely prone to that INH peripheral neuropathy we just talked about. They're also the ones who end up with drug-induced lupus from hydralazine. But they actually tend to have a better therapeutic response when fighting tuberculosis. Fast acetylators, on the flip side, clear the drug so incredibly fast that their toxicity risk is way lower. The catch is, they might need significantly higher doses just to get the drug to be clinically effective. Section 3, G6PD, HLA, and other variants. These next few concepts are guaranteed show-up topics for Vivas and short notes. Okay, G6PD deficiency. You've definitely heard of this. It's an X-linked inherited disorder where red blood cells become super vulnerable to oxidative stress. The mechanism is straightforward, but potentially lethal. Classic precipitating drugs, like the anti-malarial Primaquine, deplete the cell's protective glutathione. And without that glutathione, the red blood cells just can't handle the oxidative stress, and they literally pop, causing massive intravascular hemolysis. And that is exactly why screening your patients before starting Primaquine is an absolute must. Let's talk HLA associations. You need to basically take a mental screenshot of this specific table, because these are easy points on any exam. Give the antiretroviral Abacavir to someone with the HLA-B *5701 variant, and they'll develop a severe hypersensitivity syndrome.
Or if you prescribe carbamazepine or phenytoin to a patient of Asian ancestry carrying the HLA-B *1502 variant, they are at a massive risk for severe rashes and Stevens-Johnson syndrome.
Here's another classic variant, maternal mitochondrial inheritance for aminoglycoside ototoxicity. Certain families carry a specific mitochondrial mutation, M.1555A to G, which actually causes deafness when they're given aminoglycosides. Just use this triple M trick to remember it. M for mother, M for mitochondrial, M for aminoglycosides. Drop that mnemonic in your written answer and examiners will absolutely love it.
Section 4. Precision Medicine and Oncology. Want to really stand out? Show them you know the latest 2025 and 2026 clinical guideline.
So how does all this genetic theory shape modern patient care? Well, this is the core workflow of precision medicine. First, target identification, like finding an EGFR-positive mutation in a patient with non-small cell lung cancer. Second, companion diagnostics, which means screening the patient's genetics to make sure they match the drug. Third, targeted drug selection, like pulling out the newly approved datopotamab deruxtecan. And fourth, dose individualization, so we can actively predict and avoid adverse drug reactions before they happen.
You can see this precision approach totally taking over in the GINA 2026 guidelines for asthma. We're looking at a huge paradigm shift here. Asthma is now being treated aggressively based on genetic phenotypes and biomarkers using targeted anti-inflammatory biologics, not just tossing short-acting beta agonists or SABAs at the problem. For instance, allergic asthma, that gets omalizumab. Type 2 inflammation gets dupilumab. Eosinophilic asthma gets the new long-acting anti-IL-5, dupilumab. And the guidelines are super clear on this. Excess SABA overuse is incredibly dangerous because it leads straight to lactic acidosis.
Precision medicine also applies perfectly to how we handle supportive care. Keep this number locked in your head, 92 to 96%. The latest guidelines mandate that oxygen administration needs to be strictly protocolized. You only give oxygen if that SpO2 drops below 92%, and your target is exactly 92 to 96%. Why so strict? Because giving excess oxygen can worsen hyperoxia and mess up the ventilation-perfusion match. It is definitely not a benign, harmless therapy. Section 5. Rapid-Fire Viva Q&A. All right, let's turn up the energy. We're going to run through a high-pressure Viva simulation right now to really lock all this information in.
First question. A patient of Asian ancestry develops a severe rash on carbamazepine. Which genetic variant should have been screened? Think back to that table we looked at.
Boom! It's HLA-B 1502. And remember, if you get this in your Viva, highlight the ethnic association. That Asian ancestry is your massive clinical clue.
Next one. An asthma patient presents with worsening tachypnea despite repeated SABA nebulizations. What is the diagnosis? This is a sneaky one straight out of the new GINA 2026 update. What's happening biochemically? SABA-induced lactic acidosis. That excess beta-2 stimulation ramps up glycolysis and lactate production. It creates a terrible cycle. The doctor sees the patient breathing fast, gives more SABA, which just causes more acidosis, presenting clinically as even worse refractory tachypnea.
Okay, next up. A patient given a standard dose of codeine goes into respiratory arrest. What is their CYP2D6 status? Think about the prodrug mechanism we discussed.
They are an ultra-rapid metabolizer. Their liver did a massive, insanely fast conversion of that codeine right into a lethal dose of morphine. It just shows you how understanding pharmacogenomics is literally a matter of life and death.
So as we wrap up this explainer, I want to leave you with one final question to think about. How will you use this genomic blueprint to not just absolutely crush your exam, but to safely prescribe in your future clinical practice? You now have the toolkit to look past the surface symptoms and actually treat the genetic individual in front of you. Keep reviewing these concepts. Absolute best of luck dominating your MUHS MD Pharmacology exams, and I'll catch you next time.